So the talk by Professor Agarwal on advances in male infertility will be the following, and now I will give my talk. So I'm happy to deliver this talk on the value of SDF testing. Does SDF testing, sperm DNA fragmentation, add value into the management of male infertility? And here are the learning objectives of the talk. Firstly, specifying the main indications of SDF testing, and also to highlight the impact of SDF testing on the management of male infertility. And at the end, we will suggest a practical therapeutic algorithm for male infertility cases with high SDF. I have no disclosures. And here is the outline of this presentation. We'll start with an introduction, with definition of sperm DNA fragmentation, the impact, what is the impact of SDF on assisted reproductive techniques, ART outcomes, what are the SDF implications on the management of male infertility. Then we will have a case discussion, 3 cases, and we will finish by the take-home messages. So, sperm DNA fragmentation, as you know, is one of the mechanisms through which oxidative stress contributes to male infertility. And it could be about single or double breaks in the strand of DNA. And as you know, male infertility, it is a concern with interests about 186 million of couples worldwide, and still the semen analysis remains the cornerstone in the exploration of male infertility. But let us ask the question, is it really sufficient? Is it enough? So what is about measuring SDF, and what are the clinical implications if we find a high SDF value? And here is an attempt to explain the pathophysiology of sperm DNA fragmentation. So the phenomenon is either in the testis or in post-testicular. So in the testis, during the spermatogenesis, we may have a defective maturation, which is related to the protermination, the phenomenon of replacing the histones bound to the DNA by proteins. And this is the action of an enzyme called topoisomerase, which is causing breaks into the strands of DNA. But if this broken strand of DNA is not properly repaired, then we have a defective maturation. Also, if there is single strand breaks, they will be replicated, and then we will have double strand breaks if there was no repair. The second phenomenon, always during spermatogenesis in the testis, it is about the apoptosis, and the objective of why there is apoptosis is to eliminate some germ cells with damage in their genetic and DNA. And also there is the post-testicular process with the oxidative stress, when there is an imbalance between the ROS, reactive oxygen species, and antioxidants. So we will have a talk about oxidative stress by Professor Agarwal. And what are the risk factors of high SDF? So there are exogenous factors, exposure to some chemicals, some diet errors, also exposure to radiation, heat, and also smoking and consumption of alcohol. But also there are endogenous factors such as obesity, varicocele, cryptorchidism, and longer abstinence period, and also aging. So how to measure SDF? There are mainly 4 techniques: the channel, the comment, SCD, and SCSA. So what is the principle of these 4 techniques? For the channel, so it is based on the incorporation of an enzyme, the nucleotidyl transferase, the UTP enzyme, into the DNA breaks, and it made the fragmented DNA fluorescence during the test. Second assessment tool is named COMET, and it is about an electrophoretic assessment of fragments of DNA, and in this technique the size of the tail of the sperm corresponds to the fragmented DNA. The third technique is about SCD, and it is an assessment of the dispersion of fragmented DNA. So the fragmented DNA will not produce some halos. And also the finally the SCSA, the fourth technique to measure SDF, which assesses the susceptibility of DNA to denaturation, and as a result, the normal DNA will be apparent green, and the fragmented DNA will have a color orange-red. The thresholds following the literature to say this is a high SDF varies following the technique. So for the channel, greater than 15, it is considered high SDF. For the comet, more than that, so 52, SCD 30, and SCSA 27. So we can note already there is heterogeneity in these techniques. So interpretation should be carefully made. What are the advantages? Each technique has its advantages. For the channel, it's a direct measure. Also, it will be applied for fresh and frozen samples. It detects both single and double strand breaks. For the comets, also, it is a direct measure, and it detects multiple types of DNA damage, and it can be performed in patients with severe oligospermia, as only 5,000 sperm are required. For SCD, it is a simple technique, and there is an availability of the commercial kit. And for the SCSA, it has a standardized protocol. It's a rapid test, and it could be applied for fresh and for frozen samples. What are the disadvantages? For the channel, there is need for standardization between laboratories, and also it is a time-consuming technique, but it does not evaluate the immature spermatozoa. For the comet, it could only be performed on fresh samples, and there is also an inter-observer variability, and also it is a time-consuming technique, and it needs experienced observer. For the SCD, it is an indirect measure. There is also inter-observer variability and a time-consuming technique. For SCSA, it is also an indirect measure. There is no commercial assay available. It requires expensive instruments, and it needs also experienced technicians. So, what is the impact of SDF on ART, on assisted reproductive techniques outcomes? First, what is the impact of high SDF on intrauterine insemination, IUI? So here we have a meta-analysis which included 10 studies, and in these studies the tests used were SCD and SCSA, and they used different cutoffs. So they concluded there was a lower pregnancy rate and also a lower delivery rate in cases of high SDF after intrauterine insemination. So poor ART outcomes, specifically IUI in case of high SDF. So what is the impact of high SDF on IVF, in vitro fertilization? So here we have another meta-analysis published in 2021, and it includes 8 studies. It was about 4,555 IVF cycles, and they found lower implantation rate and pregnancy rate after IVF in cases of high SDF, and also there was statistically not significant, but it is obviously a lower live birth rate as well. Now, what is about the impact of high SDF on the intracytoplasmic sperm injection or ICSI? Here is the same meta-analysis, and we found no significant difference following ICSI. However, in another meta-analysis, we highlighted that there is a high risk of miscarriage after ICSI. So in any technique of ART, there is poor outcomes if our patients present high SDF value. So what are the SDF implications on the management of male infertility? So let's talk about varicocele first, varicocele and sperm DNA fragmentation. There is a paper published in 2023 by the Global Embryology Forum. It was a huge survey, global survey. So we have, given that the fact that adverse impact of SDF on ART, whatever the technique, IUI, IVF, or ICSI. So it is not really reasonable to use ART as a management strategy for infertile men with elevated SDF. And when we asked the participants in this survey, they said the majority will attempt conservative management first for unexplained male infertility and idiopathic male infertility patients with high SDF, then refer to ART following 6 months of failure with conservative strategies. What is the difference between unexplained and idiopathic? Unexplained male infertility when we have normal semen parameters and also a normal gynecologist evaluation, and for idiopathic male infertility there are anomalies in the parameters of the semen, but we do not know why. This is why we call it idiopathic. So this is the difference between unexplained and idiopathic male infertility. So participants would attempt a conservative approach, and what was the experts' recommendation? So they said ART methods are not recommended as first-line treatment strategies for infertile men with high SDF. And we need really to lower the SDF first. So ART is not the magic solution. So SDF and varicocele, here we had a systematic review and meta-analysis published in 2021, and it included 19 studies involving 1,017 patients, and they demonstrated that varicocelectomy reduced the SDF rates in infertile men with clinical varicocele. And the effect of this, the cure of varicocele was greater in men with high vs normal preoperative SDF values. So greater the value of SDF with varicocele, better will be the effect and the effectiveness of this varicocelectomy. Better is the indication to make this. And following the guidelines of the EAU, varicocectomy may be considered in men with raised DNA fragmentation. So it is a recommendation by the EAU, with otherwise unexplained infertility or who have suffered from failure of one of the ART techniques, including recurrent pregnancy loss, failure of embryogenesis, and implantation. So if we have in the medical history a failure of IVF or ICSI, we should test the DNA fragmentation, and if there is a clinical varicocele, we should undergo this surgery. So what is about antioxidants? And there will be a dedicated talk about the antioxidants. There are many compounds that may interact in different levels and with different actions, so motility, integrity of DNA, etc. This will be a talk dedicated to antioxidants. And here was SDF and antioxidants. This was a GAF survey, and we asked the participants, do you prescribe antioxidants for infertile men with elevated SDF? And we have the half of participants who say yes, about 50% of participants say yes, they will prescribe antioxidants in this situation. And there is, in the literature, some evidence. There is improvement in oxidative stress and SDF with antioxidant treatment, but we should be careful, because if we give an excessive antioxidant supplementation, we can cause harmful redox stress. And the experts' recommendation by the GAF, so they say, although there remains no consensus, but empiric antioxidants may be prescribed for infertile men with elevated SDF. This is the guidelines of the EAU. So there is still conflicting data. So no clear recommendations. Also for the AUA and SDF guidelines on antioxidant treatments. And here I pass quickly for this systematic review and meta-analysis of RCTs. We will return to this topic at the dedicated talk of antioxidants. So here, Professor Agarwal and collaborators in 2020, they have published this paper and suggested this algorithmic treatment, so therapeutic algorithm. So for an infertile couple who will be evaluated, if we find one of the following situations. First, if you have unexplained or idiopathic infertility, or if we have recurrent miscarriage, pregnancy loss, and if you have some lifestyle risk factors suggestive of high SDF, like obesity, smoking, etc. If we have clinical varicocele, if we have recurrent ART, such as IUI, intrauterine insemination, or IVF, in vitro fertilization failure, if we have failure of some cycles of this ART, this is an indication to measure the SDF. If we find a high SDF value, then we have the first line treatment. We can start by a conservative approach to try to lower the SDF. So we can suggest recurrent ejaculation. If we shorten the period between the ejaculations, it will improve the SDF. also antioxidants. We can prescribe this in cases of high SDF. We also should counsel our patient to improve his lifestyle, diet, physical activity, etc. And also, if there is a context of male accessory gland infection or inflammation, we can control this by antibiotics or anti-inflammatory treatments. In cases we have varicocele, clinical varicocele, there is an indication for varicocelectomy. We will see this with Professor Kanan. We will talk about varicocele in details. And also, there is after this first line treatment, if there is persistently high SDF, we can suggest an intracytoplasmic sperm injection. And following ICSI, if there is still failure or pregnancy loss after ICSI, we should recontrol the SDF, and then we can suggest other solutions like sperm selection and also to use testicular sperm by TZ. Okay? And here is a simplified algorithm for the management of high SDF. So if we have high SDF after varicocelectomy, so we can go for ICSI. And then if we have recurrent miscarriage after ICSI, we can suggest even sperm selection techniques or testicular sperm. Of course, for the conservative management of high SDF, we should always take into consideration the age of the partner. Because if there is a low ovarian reserve, we cannot wait for a long period to improve the sperm. For example, we can use the sperm from the testis, testicular testis, with ICSI. So it is really discussed case by case. So now we have a case discussion, and let's start with the first clinical case. So the first clinical case, it is about a 33-year-old man who presents with complaints of infertility. He and his wife have been trying to conceive for the past 3 years. His wife is 30-year-old, G0, P0, with normal evaluation under the care of gynecologist, and the couple has previously failed 3 cycles of intrauterine insemination and 1 cycle of in vitro fertilization cycle. And the first semen analysis showed a volume of 3 milliliters, pH at 7.6, concentration of 17 million, and motility at 40%, and progressive motility 32%, and morphology at 5%. And the second semen analysis volume was 3.5 milliliters, pH 7.5, concentration 15 million, and motility 45%, and progressive motility 33%, and the morphology 7%. On physical exam, he has normal BMI, body mass index, normal circumcised phallus, testis descended at 16 milliliters bilaterally, and there was a bilateral grade 3 varicocele, a clinical varicocele, and also there was bilateral vasa, and epididymis were palpable. So in this situation, would you test SDF? In this case, what do you think?
Yes.
Yes? Why would you test for this?
Unexplained infertility because the sperm looks normal.
Yes.
About concentration, mortality, morphology, but we don't know about the fragmentation of DNA. So we should do the SDF.
Okay, so probably this is a problem of the integrity of the sperm DNA, exactly, and due also to previous ART failure. So this is also, there is two reasons. So it was recommended to undergo SDF testing because he had a failure of 3 IUI and 1 IVF. And the SDF effectively was elevated at 67%. Given the fact that the patient had varicocele, would you suggest varicocelectomy? Obviously, yes. And exactly so, he was counseled regarding treatment options, and he elected to proceed with bilateral varicocele repair by microsurgical sublingual approach. And his postoperative semen analysis at 6 months demonstrated volume 3.2 milliliters, pH 7.6, concentration 23 million, motility 58%, and progressive motility at 45%, and morphology at 9%. So we can see there is also an optimization of semen parameters, and repeat SDF testing was 15%, so the SDF was lowered, and the couple used time intercourse and reported a pregnancy 6 months later. Second clinical case, a 42-year-old male presents with complaints of infertility. He and his wife have been trying to conceive for the past 10 years. His wife is 40-year-old G0P0 with low ovarian reserve. They have attempted IVF, 2 cycles of IVF, which have all been unsuccessful. They had no healthy embryos developed from previous IVF cycles. Semen analysis volume 2, pH 7.6, concentration 7 million, motility 30%, progressive motility 5%, morphology 2%. On examination, he has normal BMI, normal circumference phallus, testis descended and 20 milliliters bilaterally, no palpable varicocele, bilateral vas, and epididymis palpable. Would you test again SDF in this case? Yes. Why? For failure of IVF. Yes. So effectively there was recurrent IVF failure. So SDF was 45%. What do you recommend for this couple?
Not that side.
Will you give antioxidants?
Yes.
Who will try first treatment, conservative treatment? So no one. So due to the low ovarian reserve, the couple was recommended to undergo another IVF cycle, but this time using testicular sperm instead of ejaculated sperm, because there is better values of SDF, less oxidative stress. And also during this cycle, 6 eggs were retrieved, 5 eggs were retrieved, and 4 healthy embryos developed, and the couple underwent embryo transfer and now 3 months pregnant. Case number 3, a 35-year-old male presents with complaints of infertility. He and his wife have been trying to conceive for the past 2 years. His wife is a 30-year-old G0P0 with normal evaluation. So the first semen analysis, there was a concentration of 30 million, motility 45%, progressive motility 35%, and morphology at 4%. No big difference at the second semen analysis. So how would you manage this case? There is a normal gynecologic evaluation for his wife.
Start with insemination.
Insemination. So is it enough to evaluate the male partner by the semen analysis?
SDF.
So who will test for SDF? Yes. So we'll try. So this is a situation of unexplained infertility. So we offered the SDF testing, and this was elevated at 38%. He has a past smoking history of 2 packs per day for the past 15 years. Physical exam revealed normal BMI, normal thyroid testis descended bilaterally, no varicocele clinically. So he was started on antioxidant therapy, advised him to quit smoking. And 6 months later, after smoking cessation, antioxidant therapy, so conservative approach, there was effectively low value, 18% of SDF, and the couple was able to naturally conceive after 9 months. Conservative. So, take-home messages. So SDF measurement is indicated in the following situations. First, unexplained or hepatic infertility, in cases of recurrent miscarriage, in cases of lifestyle risk factors, obesity, varicocele, clinical varicocele, also in cases of recurrent IUI or IVF failure. High SDF is associated with poor ART outcomes, whatever the technique, IVF or IUI, there is lower pregnancy rate, lower live birth rate, and not after ICSI. However, there is bigger, highest risk after ICSI of miscarriage. So high SDF result has an impact, in fact, on the management strategy of male infertility. We should recognize that ART is not an immediate treatment to suggest for high SDF, given the poor outcomes in cases of high SDF. We need a good quality of sperm before going to ART, whatever the technique. We need also to lower the SDF by conservative management, such as improvement of the lifestyle, prescription of antioxidants, and we should be careful not to exceed the recommended doses, and we could suggest also recurrent ejaculation to our patient. If there is any sign of in favor of inflammation or infection, we can prescribe antibiotics or anti-inflammatory treatments. And also we may choose to upgrade the technique of ART to ICSI. It should be discussed case by case. In some situations there is an emergency. If we have a low ovarian reserve, if the female partner is still young with a good ovarian reserve, we can delay, we can try to improve first. And finally, we can suggest other solution, but this is the third line treatment, sperm selection, or TZ. So we can go to extract testicular sperm directly from the testes, only by TZ, not micro TZ, only by TZ, simple biopsy. Okay? If there is still persistent high SDF after the third and second line treatment. Thank you very much. Now I think we will switch directly to the talk by Professor Agarwal, and then we will have a discussion session to discuss the artificial intelligence and also SDF value into the management of male infertility.